Welcome to a series of recorded virtual forums entitled Healthcare Cleveland, COVID-19, 2020 and Beyond. Hosted by Case Western Reserve University School of Medicine, I'm Stan Gerson, Interim Dean for the school. We held these forums prior to the first presidential debate on September 29th. Broadcast from our health education campus, a new state-of-the-art teaching and learning facility that the university shares with the Cleveland Clinic. One of the topics for the debates is healthcare. And through these forums, we hope to showcase Cleveland's robust medical community, the nation's leader in research and delivery, biotechnology and innovation, medical and interprofessional education, and healthcare reform. Each forum includes panelists who are experts across our faculty, from our affiliated hospitals and national and community health partners. Through them, we will show how we rapidly pivoted and have been managing the COVID-19 epidemic here in Northeast Ohio, as well as other pressing issues affecting global healthcare today. We hope you enjoy these lively discussions, expert opinions with real-time examples, and audience participation. And we hope that they will help share your perspective on the political environment and decisions we have to make this fall.
Good morning, everyone. I'm happy to be here this morning with everyone to moderate one of the series of forums entitled Healthcare Cleveland COVID 2020 and Beyond, hosted by Case Western Reserve University School of Medicine. In the week before the first presidential debate, the School of Medicine is hosting this series of live virtual forums featuring leaders in the healthcare field, covering pressing issues affecting global healthcare today. Cleveland is one of the nation's leaders in healthcare with 4 world-class medical centers surrounding the School of Medicine, training tomorrow's physicians and scientists. And this is our opportunity to deliver our perspective to the nation. The panel today will be discussing COVID-19's collaboration from a shared hospital and public health efforts perspective to care for the greater Cleveland area. My name is Brian Lane, and I'm the President and CEO for the Center for Health Affairs. And it's a pleasure to be here with all of you. I'm going to ask each one of my panelists, starting with Terry Allan, and then going to Sam, Alice, Todd, and then Brooke, to introduce themselves. And then I will give you a little bit more details regarding this event. So Terry.
Morning, everyone. Happy to be here. Thank you, Brian, for hosting, and thank you to Case for putting together this group of folks who have been integral to the response. So I'm the health commissioner at the Cuyahoga County Board of Health. We serve about 880,000 greater Cleveland citizens in 57 communities, and public health has been essential certainly to the response from the beginning around case investigation, contact tracing, public messaging, guidance for a whole range of sectors in the response, enforcing the state orders that have unfolded in the face of the response, and also working very closely with our partners here from clinical medicine. We are, as I've found a saying, we were separated at birth and we are amidst a reunification with medicine, and I'm glad to be here.
Excellent. Thank you. Sam.
Good morning, and thank you again for having me this morning. This is an incredible group that's been brought together to talk about really some incredible collaboration. I work for University Hospitals as a System Vice President of Operations and Logistics, and during COVID, I've been asked to lead our planning section as it pertains to hospital incident command, looking at innovative ways that we can bring care into the community and drive collaboration across the community with health systems and public partners to drive value and look at opportunities and ways that we can mitigate the ongoing spread of COVID in our community. Thanks again for having me.
Dr. Alice Kim.
Good morning, and again, I want to thank Case and Brian and the Center for Health Affairs for inviting me as well. So my name is Alice Kim. I work at the Cleveland Clinic. I'm an infectious disease staff physician there. I also have a role in medical operations as a medical director of a few programs, but over with the COVID effort, I've helped Dr. Wiley, who is the zone commander, lead the clinical efforts related to the congregate living setting COVID efforts that we've led here in Ohio in Zone 1. So thank you.
Thank you. Dr. Todd Smith.
Good morning. I want to thank Case for inviting me to join this great group. My name is Todd Smith. I'm the Deputy Chief of Staff for Operations at the VA Northeast Ohio Health System. My clinical background is along the acute care continuum, so as a hospitalist and in emergency room practice, and my role with the COVID response was as the clinical lead for our Incident Command Center.
Excellent. Thank you. Dr. Brooke Watts.
Good morning. As you can see, it's a sunny day here in Cleveland. And I'm just so happy to be here with some of my absolute favorite people. I am a general internist by training. I worked in the VA for many years with Dr. Todd Smith with a focus on new models of care, which turns out to be something that's particularly relevant in this time of COVID. And we've been lucky enough to have the opportunity to think about those new models of care and how they could serve the community during this difficult time.
This is an amazing team. I just want everybody to just note, I'm going off script for 1 second, for the perspective, just thanking every single one of you for working together. Your integration, your collaboration, your partnership has enabled us to keep that surge number extremely low and keeping us safe and secure. So thank you, thank you, thank you. For those who have joined us for this discussion live, I want to say a couple of things. One, please use the chat box to submit your questions at the bottom of the screen. So you'll look left on the screen and you'll see the green share button. Click that on chat. A white rectangle will appear on the right of the screen. Type in the question at the bottom. Hit enter again on your keyboard to submit the question. We'll begin to address those questions. Our aim is around 9:45. And give or take a couple of minutes. So I just want to put that out there. The forum will end at 10. And so let's dig in and let's start with our first core question here. So I've got an open question. I know we just talked about our titles with our respective organizations. But each of you have been involved in setting up and running your own independent incident command centers at your respective organizations. Can you talk about what that was like in the earliest days of the pandemic and what your learnings have actually been? And I'm going to start with Dr. Kim.
Sure. Thanks, Brian. As one of the medical directors in medical operations, I did hold one of the leadership roles early on. So I can say I was really proud of the organization. It was a team of teams approach. Everybody rallied, many different sectors from our organization, emergency management, supply chain, all the clinical leads, all the administrators, all were in as we were, trying to understand what the dynamics were of this virus that was novel to everybody in the world. So I'm just going to maybe focus on a little area because I know my colleagues here have also had great experience in their incident command centers. But for me, my role really was with a team from the infection preventionist group and my colleagues in ID. It was really trying to get guidelines out with infection prevention and control. And of course, that was very dynamic. It was ever changing, and we were trying to make sure that we were all aligned with CDC guidelines, WHO guidelines, what our public health partners were, instituting and managing as well. So that was an ongoing process, and I think we did a great job not only making sure that we gave the right guidance, but also made sure our caregivers, our patients were all safe and comfortable with the guidance that we were giving. So again, I just wanted to say that we all rallied. I'm so proud of our organization and the model of how they approached this, like I said, still ongoing dynamic pandemic that we're living in.
Dr. Smith, would you like to add to Dr. Kim's?
Yeah, absolutely, Brian. The first day, the first days of the incident command and the response, they were intense. As Alice mentioned, we changed all of our clinical operations overnight. Things that we would, deliberate over for maybe, decisions we would deliberate over for maybe days or weeks or months, we were making in 30-minute meetings and then going to the next thing. And I think that rapid decision making as well as the rapidly evolving science, once again, that Alice mentioned, the two things that I think I can speak to. One is that that rapid those rapid changes really made communication so important from incident command to our organization, to our patients, and throughout the community. I think, we saw the same thing in regard to the public health response and through public health channels as well. The second thing was really we tried to be proactive in our decision making. I think one of the things that really helped us was having predictive modeling for what we thought our ICU bed need was going to be, what our testing capacity was going to need to be. And I think, we were sharing those models, around all of the different academic medical centers. And I think it allowed us, one, to make informed decisions, but also going back to that communication piece, it gave us the how and why when we were communicating with people as to why we were making different decisions.
Dr. Watts.
I couldn't agree more, particularly with the comments that Dr. Smith just made. I think we're all, for those of us that were relatively new to the incident command structure, were shocked and amazed at how quickly we can make really important decisions and execute on them in a very limited time frame. And some of those decisions, I think, were really key to helping to keep our community safe, primarily the switch to telehealth. Here at MetroHealth, we went to about 80% telehealth visits. I think that's pretty comparable across the other systems, as well as standing up our Dr. COVID line, which is our hotline that's fielded thousands of calls from the community. And early on, especially when there wasn't testing access, was instructing people who were symptomatic but doing okay to stay home to minimize exposures in the community. And it sounded great at the time, but I think, it was really a matter of getting it done quickly, and incident command structure allowed us to get those kinds of improvements and new models in place to try to keep the surge down.
Sam Brown, can you add to that?
Incredible comments, and really, I think we all had very shared experiences. Speaking a little bit to the mechanics of standing up incident command, and I presume that this is very similar across the health systems. Often we would look at and prepare for incidents mostly pertaining to episodic incidents, and I'm not sure that many of us had actually thought through mechanically how to stand up a long-standing response to a pandemic outbreak. So the exercise of ensuring that we built the infrastructure literally overnight with a command center, command post, and filtered that all the way down to the front line in order to effectuate this communication really was just something to behold across not only the UH network, but across all the health systems. The communication and ongoing dialogue that started very early on across all the health systems really was quite remarkable. And I think to Dr. Smith's point, it allowed us to start to think and to throw ideas off of each other so that we could all benefit from the knowledge and the thought process across a much broader network. So while all of us were busy planning for different scenarios, the initial indications were somewhere in the neighborhood of a 300% surge, and how we would accommodate that as a group really allowed our incident command structures to collaborate and to think collectively with our public colleagues about how our structured approach could not only ensure the safety of our caregivers, but really how we could bring care to the community, both in disease prevention, but also as folks did get sick, both within the Cleveland area, but if it were to expand further out and we needed to receive patients as a regional hub, how that exercise would work, how the mechanics and how we would collaborate going forward has really been a fundamental piece that, at least for me, will stick with me for a long time. And incredible work across multiple verticals in Northeast Ohio.
To say the least. I mean, it's extremely impressive, and I thank all of you for your leadership and your ability to collaborate. So people often say, we're building the plane while flying it with respect to COVID. Can you talk a little bit about what that looked like, particularly with respect to the collaboration between the hospitals along with public health? And then had working together at this level ever happened, before? And how did this, literally kind of take shape, in the middle of the full pandemic response? I'm going to start actually with Terry Allan.
Thanks, Brian. So, I think we learned many years ago, I've been in public health for 30 years, that there was a executive officer at the Cleveland Fire Department that said, you don't pass out your business cards at an incident. So getting to know each other in advance, tabletop exercises, interactions with medicine and public health in the community are critical But in every situation going back post 9/11 to anthrax and smallpox, H1N1, Ebola, all those situations, there is this fog in the moment that is part of any response. You almost have to be comfortable with that discomfort in the process. But that the organization with emergency operations centers connected with, setting up a regular cadence of discussions, you're able to sort of iteratively solve problems, because inevitably, what are we doing? We're amidst a whole range of unanticipated problems and evolution of messaging and guidance that is part of any response. And so for me, once you accept that reality and you move together, then it's our job in leadership across sectors to control that temperature and try to assure that we're sharing similar messages to the public. And I think we've worked to do that in the face of what has been, like all events, an ever-evolving situation with lots of twists and turns.
Thank you. Dr. Watts.
So the most vivid memory I have, I think, and I will keep from COVID, relates back to some early conversations with Terry Allan and Dr. Heidi Gullett. And we were lucky enough here at MetroHealth to stand up the first 2-hour test. So we had the first rapid test in the city. So we were doing some of the first testing for public health as we started to look at outbreaks. And we had a conversation because we were very concerned about a group home for the developmentally disabled in Cuyahoga County that appeared to have cases. And at the time, this was late March, early April, we really didn't have a structure in place to be able to, what do you do? These were folks that trying to bring them into the emergency room or otherwise would be extremely disruptive. And partnering with public health, we deployed the first MetroHealth remote response team to test in that facility, and I went with that team. And I think that was the moment for me that everything changed, because what I saw was people with very severe developmental disabilities who clearly can't do social distancing, can't mask, being cared for as best they could by workers who make a nominal wage, and really had no experience in infection prevention. And in that case, that the fact that we were able to take our team in with Terry and Heidi's support and do the testing, which then guided the next steps in isolation, was really powerful. And I think that one particular event laid the foundation for the rest of the mobile testing that we've been able to do with the county, which now counts more than 10,000 tests done in parking lots, nursing homes, and other homeless shelters. I think we've done more than 2,000 in homeless shelters, so very vulnerable environments, and truly an opportunity and a partnership with public health.
Impressive, very impressive. Sam Brown, you got any comments to add to this question?
Yeah, I think if I think back to the early days, sitting on conference calls all day talking about what we thought might happen, the thing that was, I think will stick with me is really a sense of fear, to be honest. And it was palpable across our caregivers and across our community. And being open and honest about what this really meant to us and how we were going to tackle this problem together. The collaboration that went on as it pertained to our masking and PPE policies across all the health systems, our approach to congregate living that Dr. Kim led and spearheaded with a number of colleagues, our testing strategy, our co-testing activities, looking at our analytics and how we could combine forces together to better understand disease spread and how we were going to respond to these things, working through the county EOC to help coordinate and build a common transfer protocol to make sure that no one health system felt the total burden. This really was an incredible moment, I think, in Northeast Ohio to see these incredible medical facilities and academic medical centers and health systems collaborate for the common good of our community. So in a time of fear and the unknown, there were many folks that rose to the occasion, both on the front lines and through the hospital leadership and regional leadership to come together to provide service to our communities. And I will forever remember the early days as this was progressing.
Excellent, excellent. Dr. Kim?
Yeah, I just want to reiterate all my fellow panelists have said. I've always said that COVID, with all the badness, has really been, some good has come out of it. It's really been a catalyst for change. I think all the health sectors were sort of functioning in silos, sort of in parallel. But I think the pandemic let us intersect and build relationships. And I really think the zone approach that Ohio built up to for this response was, right on point. Meaning that with the good zone leadership that we had with Dr. Wiley at the Cleveland Clinic, and then partnering with our other healthcare systems, with emergency management, definitely with our public health systems, we looked beyond our own organization and realized that we had responsibility beyond our own enterprise, that we really had to pool our resources together because this was affecting everybody. It wasn't just affecting our hospital system. So I think that was great. And again, early on, having open communication, like Terry said, just to make sure that everybody was aware that we were all in. We weren't going to just let the public health sector, who we know, definitely underfunded and needs, a lot of support. We needed to be their support system, especially as we got into the congregate living setting where these vulnerable patients we knew needed not only clinical support because they were unfamiliar with infection prevention and control practices, but they needed, supply support with physical things like PPE and testing. So again, the Cleveland Clinic couldn't do it all on their own, but we brought all the health systems and assigned these facilities with, hospitals that they can go to seamlessly, that they can contact their public health seamlessly, and the public health sectors could contact the hospitals, again, easily, so that there was, assignments and an orderly process instead of haphazard, which usually happens in the time of fear and crisis, like Sam said. So again, I think out of bad, actually some greatness came out of it, and I hope this continues in the future.
Excellent. I appreciate that. And speaking from the Center for Health Affairs, it was a pleasure to work with each and every single one of you. I want to give a personal shout out to Lisa Anderson, Beth Gatlin, and their team for all of their efforts in conjunction with this whole team. Seriously, yeah, they far and above rock stars. Love them dearly. So I'm going to switch to another question here, and it's really the transformation aspect associated with COVID, and it's happened to every single one of our organizations. So during the pandemic, many organizations, not just in healthcare, but in all industries, have had to pivot and transform. Part of it's survival. Part of it is, well, is this the new outlook regarding the future? Can a few of you talk about what this has looked like for your respective organizations? And Sam, I'm going to pick on you first, my friend. And so you might want to talk about, for example, expanding research, innovation, strategic partnership, recruitment, retention, talent, training. I'm just throwing out some things. So
I think there's a couple of different verticals. Early on in the pandemic, one place that all of us realized we were going to have problems was in sourcing supplies. PPE became short, and all of the health systems looked at different supply chains. They looked at different processes to be able to reuse some of our PPE. And in our particular case, we looked for domestic manufacturing opportunities and looked for innovation from our ventures team to work with folks like Eaton and Magnet to come up with solutions that would help us deliver care in the front lines. From a mobile testing booth to domestic sourcing of PPE options, these were all things that we hadn't really considered. And when you started to look at the testing supplies, many of which were coming out of Italy, much of the PPE coming out of China, this became a real concern, not only for our health system, but for the whole country. So we went through the process of looking at how can we shore up our supply chains in order to have some resiliency and some backup to disruption that may be occurring since we're really have become reliant on global supply chains. In addition, as we think about folks working from home, we've seen a transformation in the number of folks in our back office and folks that don't need to be in front of our patients on a daily basis being very productive working from home. It's caused us to shift a lot of IT resource to support that because, frankly, we weren't built for this. But over the past 6 months, our IT team has done an incredible job of enabling folks to be productive from home and to help support our patients and our frontline caregivers. So a lot of innovation is going on, a lot of partnership with a lot of the rich history in Northeast Ohio in manufacturing to help build more resiliency as we go forward. And frankly, it will change our business model as we proceed out of the pandemic.
Excellent. Todd, you want to add to this?
Yeah, thanks, Brian. I can add from a research and innovation standpoint. I think one of the things I really thought a lot about during this was the idea of, transferable expertise, right? That we have these experts in these fields, from Curtis Donsky with C. diff and infection prevention to Usha Stiefel with MRSA and nosocomial infections to the geriatric ID group at the VA led by Robert Bonomo and especially Robin Jump with infection prevention within long-term care. None of us were pandemic experts, and so we had to take what we knew from other fields and other experiences and move that and say, we are now the COVID experts for our health system and for the community. And I think having those diverse expertise throughout our system and throughout the community is really, really important, and really the building blocks to be able to operationalize our response and put together the logistic and the guideline responses that came out was really that foundation that was already there. And so to Sam's point, I think that transition and transformation will continue as we discuss new models of care and new modalities of how we're providing clinical care.
Excellent. Since I have you, I'm going to pivot to another question. Many of the organizations here have all been working hard to address the opioid epidemic within the region per our opioid consortium. But sadly, we've seen the problems, have been exacerbated by COVID. And Todd, can you talk about the tremendous work the VA has done around telehealth, on this front? I think it's an important piece in which the community needs to hear.
Yeah, no, mental health in general has been deeply affected by COVID, and especially in our patients with substance abuse disorders and other mental health patients. And I think one of the things that we really took away from the COVID response was that a lot of things that we thought we had to do face-to-face could be successfully provided and possibly better provided through virtual modalities and telehealth modalities. And so, we were forced to instantaneously make those changes, and we've found great successes in them, from as you mentioned, mental health and substance abuse, from individual therapy to group therapy has worked over virtual modalities. Additional things that we found successes in, we have a very successful residential substance abuse program at the VA, which has worked very well. We've been able to provide a great amount of that care through telehealth modalities. Things outside of mental health that I would have never expected, from blind rehabilitation to spinal cord injury evaluations. The ability to have successes in those non-face-to-face modalities, I think, tells us that things like mental health, we can find patient-centric, great patient experiences in ways that we're just growing. I mean, the framework of that updated vision of clinical care is there, certainly in mental health and in a lot of other places that we weren't expecting to see it.
Excellent, thank you. Historically, Cleveland has been a front runner and always leading the pack from a healthcare perspective, dating back to even the Spanish flu. What did you take from the H1N1 and the Ebola experiences that each of you have experienced, and what helped you from those experiences within your organization to find success responding to the COVID pandemic? And I'm going to start, I think, with Brooke on this one.
Despite the brand new coming soon building behind us, I think most people know that MetroHealth has provided infection prevention for the city of Cleveland for about 175 years now. We're talking smallpox, cholera, diphtheria, and during the 50s and 60s, tuberculosis, and then polio. We had one of the largest polio hospitals in the country. More recently, we have the primary Ebola treatment center for the region. So anyone if there were a emerging disease such as Ebola that came into Ohio, that would be treated here at MetroHealth in our special diseases care unit, which is fitted with all sorts of fancy pants things, and I really mean fancy pants. There are fancy pants that go with the unit to care for patients with new and emerging diseases. So I think when we first heard about COVID, there was a bit of excitement from the staff and teams that run that unit. But I think we realized pretty quickly that, for better perhaps, that this was going to be something that is more traditionally transmitted as droplets and really required other kinds of expertise. But for us, I think that meant having a really good understanding of certain kinds of supply chain issues around PPE and other emerging diseases. And also really having some of the structures in place with staff training to be able to rapidly implement some new models of care.
Excellent, excellent. Terry, would you like to build on that?
Sure. I think one of the things that I've learned over the years, and really being in public health for 30 years, is that the incident command system is effective at reducing some of the inevitable churn that happens as messages change and science advances in the middle of an outbreak, and it happens in real time. As Todd explained, it's people are making decisions in 30 minutes that they might have taken 30 days to make, and it's because the moment requires it. We knew early on, for instance, during the anthrax issues that happened post 9/11, there was a message that came out from the federal level that you couldn't get exposed to anthrax from a closed envelope. Well, we found out as the science advanced that indeed you could. And of course, then the messaging had to change. So what we get from the incident command system that was set up way back when by the response to the wildfires incidents out west, that is that public safety and medicine all setting up their own incident command systems with public health unify in a combined response through emergency operations centers to assure that we are all singing off the same sheet of music in terms of our messaging, in terms of guidance, in terms of public communication, services that are available in the community. And there really is no substitute for that in my mind. And we learned that from Ebola. And we certainly are learning that that's playing out in real time here with the COVID response.
Excellent, thank you. Hey, Sam, you guys have had a good response regarding Ebola too. You want to address some of that as well?
Yeah, I think some of the learnings, several of our leaders that are relatively new to UH over the past several years had a lot of experience in managing the transportation of Ebola patients in the United States. And some of the lessons that we learned were then applicable here as it pertains to COVID. So as an explicit example, we did a lot with remote patient monitoring. So as teams would go move folks with Ebola through a logistical network, folks would then be isolated for a period of time, and we would deploy remote patient monitoring kits out to ensure the safety and well-being of the folks that were caring for these Ebola patients. And subsequently has been a strategy that's been deployed as we look at COVID. How do we bring care to the community? How do we create and allow people to stay at home, whether they be our caregivers or they be folks that come to our hospital, utilizing technology that we leveraged with Ebola and H1N1 really has been at the forefront of redeployment here as we think about COVID.
Excellent. The COVID experience also yielded a lot of other awareness, and we can't talk about COVID without acknowledging inequality and the disproportionate effect of the pandemic on communities of color. And through the community health needs assessment work that's been an extremely large collaborative effort of Cuyahoga County hospitals and city and the county public health, the elimination of structural racism has been identified as a top priority. I want to ask Terry if you wouldn't mind talking about the efforts currently underway and to address this disproportionate effect on the pandemic.
Thanks, Brian. So I'll first note that for those that are watching now, that as you know, this is part of a series of these forums that are being held. And tomorrow there actually will be a session that we moderated by our very own, our medical director, Dr. Heidi Gullett, who also is at Case Western in neighborhood family practice, and she'll be moderating a session specifically focused on issues around inequities and disparities tied with structural racism in the community, the work that's happened together with medicine, nonprofits, and government. And so tune in tomorrow for that session. So from our standpoint, what do we know that is clear as we take a breath here now and assess where we're at with this response? We know that people of color are disproportionately being impacted by this, 2 to 3 times more likely to be hospitalized or to be in intensive care in terms of needing treatment, extreme treatment for their care. And so these are issues that we know are inequities that relate back to chronic disease that have been known for many, many decades in the community and persist and are being exacerbated through this pandemic. So what have we tried to do in relation to this? We've worked very closely with MetroHealth with funding from the county executive, Armin Budish, who's funded and supported the work to conduct testing, as Dr. Watts said, in homeless shelters, in apartment complexes for low-income folks, for developmentally disabled, working with Greater Cleveland congregations and the African-American churches to bring testing to the people, to the communities, where they could drive up or walk up or bike up to be tested in their neighborhoods. And we think that's a critical way to provide services to where folks need them most so they're accessible. There are funds also that are going forward for rapid response coming down from the state to help to deal with basic needs. Folks need rental assistance. They may need getting basic meal support. Kids who are remotely and working remotely and with school-related curriculum may need Wi-Fi access. There also are a whole range of supportive services for kids who may have developmental issues where they need to come into the school in small groups and receive the care that they need to be able to learn. And so there's a range of resources that are being deployed in conjunction with the foundations in town. And we are very fortunate. We have the foundations that have come together here to form a COVID Rapid Response Fund to address these basic needs. They stepped up when we needed them, when the community needed them most, connecting with United Way to deliver critical services. So for me, that's another demonstration of that work. Internally here at the Board of Health, we've also been assuring where people may need resources, where they are isolated if they're a case or quarantined if they are a contact. Do they need medication? Do they need food? Do they need a place to stay? Are there gaps that we can help to fill, working with our partners in Emergency Operations Center? And lastly, I will say that this work now is helping inform the way that we go forward to deliver services around influenza vaccination and for a future delivery of a COVID vaccine. How do we do that safely? What are the environments that we need to assure we're reaching? Are these vulnerable populations, critical infrastructure, in ways that people can access services in their own backyard? And those are things we're thinking about now in real time.
I love it. And once again, I want to give praise to Dr. Gullett as well. That was the right thing to do. Terry, I think we should refer folks to the CCBH and the CDPH websites, and call centers for any, specific questions. You're always promoting that and all the communications. I'm going to just help you with that. I know there's a lot of questions coming in. Keep them coming. I appreciate that. There's an organizational behavior theory, that talks about how groups go, through different stages of forming, storming, norming, and performing. A few of you with your MBAs are going, but when people come together and begin working with one another, how has this whole experience with the pandemic, impacted the relationships among the different hospitals within the region and particularly among, all of you as individuals? So this is I want to hear from each one of you, in your relationships with one another and what has really set us apart from a collaboration standpoint. Because I think we have, come back around and we are number one because of this element, which is collaboration. And I'm going to start with Dr. Kim. She always brings light to everybody. So.
No, I just want to say, with all the hardship, frustrations of all this has brought on all of us, I think the greatest thing that I've come out of this is it's been fun actually seeing all these people that I've been talking to over the past few months actually on a video chat, because I've never seen them in real life. And that includes, you know, hundreds of people that I've talked to, not only locally, but regionally, in the zone and on the state level and nationally, that, you know, I think this all brought us together. And I love that we've had a common goal, but we were also able to be human about it and be able to talk about things, you know, in a you know, realistic light on how we needed to approach this situation, because it was tough on everybody, and it's still going to be tough on everybody. And I'm hoping that, again, we all look at this as, you know, we have a shared responsibility. We really do. And we cannot do this on our own. And I love that we made this network and relationship happen in the region, because I feel like I've had good friends, good friendships be made. And I really can't wait till the social distancing is released from us, and then we can all go out together and really see each other non-virtually for once. So again, with this, again, good opportunity for change, and, you know, for now and for the future.
I think that was a great summation. So I'm gonna kind of pivot and ask Dr. Watts, you know, how do you think this all will continue, you know, to evolve, and what does the future look like, you know, from, you know, let's say the next 6 months, or even the next 12 months, not just in regards to COVID-19, but kind of in a broader sense. Does the collaboration continue? Do we build upon that? You know, does it become even closer?
You know, I can't see any scenario where we can be successful if we don't continue these collaborations. And it is, you know, with incredible gratitude that I look to the leadership of Terry Allan and Dr. Heidi Gullett, that has been just unyieldingly and unwieldingly and steady for us all throughout this. And because Terry and Dr. Gullett are able to provide really the good, solid, evidence-based recommendations in partnership with the health systems, it gives us a framework. And along with the other groups that give us those voices, Brian, yours as well, to continue to partner and collaborate to really help our community understand these mixed messages. And I think when I look forward, you know, what I'm seeing in the chat box is a lot of confusion about what's true and what's not true, and who do we trust. And what I think I'm most really grateful for, you know, is that public health leadership that we've seen, and then these partnerships. So, you know, Dr. Alice Kim right here, who really is an expert in infectious disease and long-term care environments. You know, that might not have been something you would have thought would be the most important thing in COVID, but it turns out to be really critical. So the idea that we have these important expertise and this important leadership and shared safe spaces in Cleveland is really powerful. And I do think that we've been able to make decisions and work together in a way that has kept this community safe. I have no doubt it could have looked very differently.
I agree with you. Hey, Sam, I'm going to ask you to also opine on that question. I think it's important from a UH perspective.
Yeah, I mean, I think the encouraging thing is hopefully everybody saw the op-ed that was released over the weekend to talk about the ongoing collaboration that we anticipate going forward in the public health realm, as well as looking at public safety risk. As we think about the activities that are ongoing, planning for this presidential debate that's upcoming, there's been a level of collaboration across the health systems to think through emergency planning, and how does that exercise transpire? How do our systems continue to connect? And how do we continue to support our communities? So there's a multitude of different fronts. I think that will continue well beyond COVID going forward. And as Dr. Kim alluded to, you know, the friendships and the relationships that have been made during this time, the number of hours that we have all spent together on the phone, talking things out, thinking, ideating about how we can solve particular problems that are in front of us, really, in my opinion, have built incredible long-lasting relationships that will allow us to be able to reach across organizations, engage our colleagues with particular expertise, and be humble in our approach going forward and how we solve and collaborate on some of these problems going forward, or opportunities.
Excellent. Thank you for that. Terry, you know, regarding you know, the resilience, you know, regarding this community, which we're well known for. Would you like to opine just openly on that community resilience, the medical infrastructure, the communications that need to be, had, and as well as the communication needs of just the elected officials from a public health perspective. I think it's an important point to add into this mix as well.
Sure. I think first we acknowledge that amidst all of this, there's been an incredible amount of fear, anxiety, disruption, job losses that people are experiencing, access to basic needs that are not readily available. And people have died. People have lost friends, neighbors, grandparents. And so there's all that loss, is fulminating and I think exacerbating, this very challenging situation. And what we have, I think, is a very compassionate medical community that is, I think, realizing a newfound avenue through telehealth to reach people in very difficult circumstances. And I think, I don't know that we realized telehealth would be as big in an urban area as become, but it's actually, there are ways to reach people differently through this medium. And so from my standpoint, what we're finding is people come together and we are arm in arm. There's no light between medicine and public health in this response, and our range of partners in public safety. We need each other. We need to support each other. The other piece too is I find in these emergencies is public health is on the phone on a regular basis, as I know medicine is with Governor DeWine. And he's saying, what's happening out there in your communities? What are you hearing from people? What are your challenges and how can we help? And how can we work together to solve them, to address the very point that Dr. Watts made about people being confused on messaging? How do we address those and sort of tamp out concerns about misconceptions? Because inevitably they are part of any response. And so I think we've done a great job of that. We have a ways to go, we know, as we move into the fall and we move into the winter. But with resolve and with this group of folks, I'm confident that we can continue to serve the community well.
Excellent. Thank you. I want to say to the community in general, you also have the opportunity to listen in to the Cuyahoga County press conferences on Friday afternoon, and where a lot of the latest public health guidance is coming from folks such as Terry as well as Heidi Gullett, and so you want to take part in that and keep apprised. I'm going to switch gears because we're at 9:47, so I've got some questions here. I'm going to throw out from that have come in. The first one, actually, it kind of falls in line with what Dr. Watts was saying. How do we process the confusing messaging that's come out of CDC and the misinformation from Washington regarding transmission and testing of COVID? So I want to put that onto the table. Dr. Watts, would you like to opine on that?
Thanks. I'm not sure I have a good answer except to say, look at the people on this call. So I myself, I think we all struggle with some of the mixed messaging that's happening in the media. And boy, if you don't put that phone down, you could hear, 50 different messages in the course of a day.
I agree.
We are very lucky in this environment. We have experts here with the health systems. Our medical director of infection prevention, Dr. Amy Ray here at MetroHealth, had tremendous expertise during the H1N1 epidemic when she was at her previous institution and now here at MetroHealth. We have people across the systems that are experts in lab testing. The Cleveland Clinic has really led the way, along with Dr. Christine Schmelzer from UH and some of the lab testing and options for that. These are things that not every city can provide. So we have Cuyahoga County Board of Health, our trusted source of public health information, and we have the health system. So as I look at the questions, and I struggle in the same way we all are on these calls, I'd say keep it local. I trust us. I think the health systems and our public health, we got smart people, we're working together. We will get you as best we can the most accurate information. And I did want to, because while you had me for a moment, I wanted to give one shout out to a group that I never ever thought of before this. And I know Dr. Kim and Sam Brown and Dr. Smith will agree with me. Judy Slivka I learned more about home care nursing from you than anyone else. And what I've realized lately is there are a mess of nurse managers of nursing homes that are, God bless, just doing the best they can in a really difficult environment. And having the opportunity to be on the phone with these folks, as I know we all have, while they try to manage their very vulnerable populations in a way they've never thought about before. So I will tell you out there in the group, if you know a nurse manager that does home care or nursing homes, today's the day to thank them for their work, because boy, they've really contributed incredibly to keeping our community safe.
That's great. That's great. Terry, do you want to opine on that piece regarding confusing messaging and where folks should get their information?
Well, I think, as Dr. Watt said, I think all of us have, every Thursday, many of us get together in the mornings, and I was relating that Dr. Kim has a very sort of soothing voice at 7:30 in the morning when we're all tired. She has a way of, it's a salve for us as we face the next day. And so I appreciate that, Alice. It's been wonderful. And so I think in those discussions, we're relating back not only what may be in the media, but I think even more importantly, where is the science? And what is the data from peer-reviewed journals and evidence leading us so that we come to some consensus on messages? As I mentioned, it is normal in these circumstances, something evolving as quickly as the COVID response and the science is evolving, that messages will change. And so we have to be prepared to tack and revise messages. Early on, cloth masks were not in the picture. And where are we now? We know that cloth masks may very well be our salvation through this process going forward. It's been a fantastic transformation. So that's evidence that as we learn more, and as we learn together, we do better. And we have to just recognize that these are normal parts of any an incident that's evolving rapidly, and we adjust.
Excellent.
We ask the public to be patient in that regard.
Perfect. Thank you. I've got a couple of just general questions that popped up, and I've got a slew of some other ones as well, but I'll put this out as kind of an opening piece for any of you to answer, and that is, please tell us, this is an open question, please tell us the risk of transmission of COVID outdoors versus indoors. Any numbers, any guidance being outdoors?
Well, I think the studies have shown, the ventilation and the air currents and everything like that is actually good. Again, that's why we've always advised if you're in a closed area, the masking and social distancing, although, for indoors and outdoors is very important, maybe more so in indoors where you don't have, the ventilation and the air going around. So I know they've done studies on it. I can't quote the numbers, but again, probably higher risk as in indoors versus in closed spaces than in outdoors, and the risk of transmissibility, just because it's a droplet and some airborne component to the transmission of the virus.
Since I have you, Dr. Kim, do you want to opine on one of the other questions that came up here, which is when will visits be allowed safely to the nursing homes in the county?
I think this is going to be something that the public health partners and all the health systems will be discussing very closely. And this has been an issue, as we know. Closing the facilities is really for, the medical issues of that, protecting the vulnerable patients from getting from community spread. So with that, I think we've come to the realization that closing them off from social interaction is not good for their mental and for further physical, recovery and health. So one of the things that, the federal and the state governments have done, especially in the nursing facility arena, is do all these aggressive, rigorous screening, restrictions, and most of all, testing. I think when we look at that sector, the testing has really been very prioritized to that group. So they are looking at it. I know it was facility sort of based. If they didn't have any positivity in a past couple weeks to months, that they were able to at least start with outdoor visitations and like so slowly open that up. But we really want the facilities to work with the public health partners to make sure that guidance, you know, is again, the message is clear. We're not having discrepancies in how we bring that about through the community. Because again, I think this messaging, like we've been talking about, has caused a lot of fear and some anxiety. But as we look forward, I think consensus among the healthcare systems, the facilities, and public health partners is how we need to go moving forward.
That's awesome. Thank you. I really appreciate that. We have a question actually from another person here. This is a surprise one for the panelists, but from another one of our colleagues and peers, but from the AHA, and that is from Nancy Myers, whom we cherish and love. But she wanted to first state, you know, thanks for your service to the Northeast Ohio community. I know you are all working separately on workforce support and resilience as our healthcare team members continue to manage the pandemic. I'm wondering if you are all doing any collaborative planning and programming or strategizing within that area. So I thought I'd put that on the table from one of our colleagues. Sam? You got an outfit talking about it.
Yeah, it's been an area of focus, was recently discussed again in the op-ed article around how we do develop our workforce, working with our local educational institutions to continue to support them. Really, as you think about the infrastructure that's in Northern Ohio as it pertains to healthcare, there's a lot of activity that comes in from outside of our marketplace, which means that our physical footprint is sizably large compared to the populations that we serve, and we benefit from that. But one of the challenges that we have is our population and its aging, and how we continue to develop our workforce really from the ground up. The health systems have committed going forward to work collaboratively to do this, because at the end of the day, we need a strong working nursing workforce. We need lots of technical skills, physicians and providers. So all these pieces are areas that we are working collaboratively to develop with our educational institutions going forward.
Excellent, excellent. We're going to do a rapid fire one here. We only got 3 minutes, and so I'm literally going to go down the list, starting with Terry, then Sam, Alice, Todd, then Brooke. But I'm going to ask you, if you had a wish, this is the magic wand one, you know, what would it be? Ready? Here we go. Terry, rapid fire.
I would say that that Congress at the federal level is listening to public health and medicine about what infrastructure needs to be built for the resilience to respond and in the future quickly, nimbly, rapidly to reduce fatalities, to reduce a lot of heartache and pain, and to recover quickly.
Give me a virtual high five. Thank you. All right, Sam, you go.
Yeah, I think from my vantage point, I desperately hope that we continue to learn together as we go forward. The opportunity is right in front of us as it pertains to collaboration and many of the challenges that we can tackle together. We've really proven that we can be a lot stronger together, and as we move forward, continue to build our relationships and collaborate in a number of public arenas. Perfect.
Thank you. Dr. Kim.
I want to ditto what Terry and Sam said, but again, I think the one thing I want to emphasize is sort of using innovation to move forward, using shared data like we have been between the healthcare systems to move the needle here. Because I think, again, Cleveland has the most opportunity to do that and move the state and the nation and the world forward with the innovations in healthcare.
Excellent. Excellent. Thank you. Dr. Smith.
The short term, get your flu shot. The second thing is what everyone else has said about collaboration, which is, you know, we're blessed to have 4 academic medical centers in Cleveland, and you know, team-based solutions are the way forward, not just in research, and certainly in public health. And as Alice just said, we're uniquely positioned to do that.
Excellent. Thank you. Dr. Watts.
I think I would wave my wand and hope that I could restore and instill trust in our health systems and our public health officials, not just for the flu vaccine for this fall, but going forward. I think that science has advanced to a place where we we really are starting to know what we need to do, and we certainly are going to know what we need to do when it comes to vaccination. And we need all our community to be with us on that. So there's my magic wand.
That's excellent. Excellent. Well, I appreciate everybody's time today, and I hope everyone enjoyed the event. And we want to thank again Case Western Reserve's University School of Medicine for putting this event together, and we appreciate everyone's participation. So thank you very, very much.
We hope you enjoyed this panel discussion and are leaving better informed about Greater Cleveland's medical community and how we are managing today's healthcare issues. And most importantly, how we are discovering medical breakthroughs, treating patients, and saving lives. Thank you for watching, and keep healthy and safe.